Thank you so much, Ayman. I just moved to sit there and invite some people to come. So, yep. How do I make it work? Okay. Perfect. So I start call people, and you just come here and sit for having a cup of coffee. May I just ask for the tech guys if is everything working? Yeah. Are we broadcasting already? Yep, perfect. It's a little bit of some internet issues and tech issues to make it work. So we have our feed here. So here we go. Can I ask for Pradyush come to the stage from India? Yeah. Amanda Howie from UK. Joey Jones, Bruce Chatter, Sarah Strasser, Ruth, Jean Campbell. Yeah, I would like to ask for Kensuke Takahashi from Japan. Okay, Shin Yoshida. Thomas Curry, William Moorhead, Ismir Ruti, Andreas, Tarun, Veronica, a Taiwan doctor that I just forgot his name, but please come, Zakir Rahman, and Sergius Onwuke from South Africa. And Karine Kerstin Puls from Brazil with the mate. Yeah, maybe one more. Are ever okay? Well, very good. We are in our 20th Café. I'm very happy to be here with you all. It's a great pleasure. We have loads of new people and young, and we are just, a lot of people asked to me, how it works, what we need to do, and I just need to say that we need to have some fun, talk in a very informal way, and get together. So how are we going to do that? On the Twitter, we have the hashtag Rural Café, that's just going on our back, and I just really acknowledge Dr. Ewing McPhee, that's there, and he's managing the tubes. Ewing? Yay! The Twitter man. So if you want to ask any question, you can come here and ask, but you can ask on Twitter, and we have the whole world, Africa, South America, Europe, join us on that. So we have inputs from the whole world coming on Twitter, and Karine has it working on Facebook as well. So if you want to give your opinion on Facebook, you just can go there and use the hashtag Rural Café or go in the event page, and you try to bring the whole social media here. And we are exactly now streaming it on the YouTube as well, so the whole world is watching us. So, hello world. So I will introduce myself briefly, and then I will ask for each one of us introduce ourselves. Is that okay for everybody? Okay, so my name is Mayra Foz. I'm a medical student from Brazil, and I'm really happy to be here. It's an honor. And just...
I'm Bruce Chater. I'm probably one of the closest people on this stadium to here, and that's about 1,500 kilometres away. And I'm a rural doctor at a little place called Theodore, and the secretary of the Wonka Rural.
Hi, I'm Amanda Howe. I'm an academic and a family doctor in the UK, and I'm president of the World Organisation of Family Doctors, so it's great to be here. Thanks. Looking forward to the show.
Hi, I'm Pratyush from India. I am general physician and a young doctor, and also chair of Wonka Rural South Asia.
I'm Ayman Shinoda. I'm a rural Australian doctor from Wagga Wagga, and I'm current chair of RSGP Rural Faculty.
Hi, I'm Karine Pous from Brazil. I'm a medical student in my last year. Mayara, thank you for the invitation and thank you for your presentation. You are a really inspiration for me and for another students in the world.
Thank you so much.
And hello everyone, I'm Wendy Su from family doctor from Puli Hospital in Nantou County in up Taiwan. I'm happy to be here. Okay.
Hi, I'm Veronica, junior doctor from Croatia, and I'm hoping you all enjoy this Rural Cafe from Cairns, Australia.
Hi, my name is Billy Moorhead. I'm a final year medical student and chair of the National Rural Health Student Network and a future rural generalist. Really happy to be here.
G'day, my name's Tom Curry. I'm also a final year medical student from James Cook University, and I'm the president of Club Rhino, which is rural health in the Northern Outback, the student rural health club for North Queensland.
I'm Shin Yoshida, a GP trainer from Japan. I'm also the chair of the Rajakuma movement, meaning the young doctors movement in Asia Pacific region of Wonka. I'm very excited to future collaboration of this students movement and the young doctors movement as well.
Hello. This is Zakir Rahman from Bangladesh. I am a rural family physician, and my portfolio research on Onka Rural Practice Group, Onka Working Party on Rural Practice, and I'm from a developing country like Bangladesh. More than 80% people lived in rural areas, so we are in high need to take up. Thank you very much.
Good morning, Jim Campbell, Director of the Health Workforce Department at the World Health Organization in Geneva.
Good morning, John Wynne Jones, Chair on Rural Wonka, and I'm here at the Rural Cafe with my cup of coffee.
Hi, hello, my name is Ken. I'm from Japan. My background is emergency physician, and I'm a trainee of Rural Generalist Program Japan. It's the founder of Rural Generalist Program Japan, the Manabu Saito. And thank you for invitation, Maya.
Hi, I'm Ruth Stewart. I'm a rural generalist doctor from the Torres Strait, the very northernmost part of Australia, that pointy bit. And I'm also president of ACRA, the Australian College of Rural and Remote Medicine.
Good morning, everyone. I'm Sarah Strasser, and I'm currently the head of the University of Queensland Rural Clinical School. And I have to say that the Rural Family Medicine Cafe changed my career direction a couple of months ago to take on this position.
Thank you. May I just ask for Marita and Smruti to come to the stage? Smruti Haval from India as well. I think, Smruti, you should come. I called you, Marita as well. We'll find a way to sit everybody on the stage, it's not a problem. So I'm really happy that everybody's here. And just have a talk about how is being the conference. It's the first conference that we have a whole student program. And I think it's a great thing. What do you think, guys? Who would like to start? Pictures? Yeah, we're done.
Hi, it's William here. I'd just like to say from a student perspective, I found that this conference particularly has been so supportive of us as students, and particularly the last plenary really, I think, showed the commitment that the Wonka does have to students and rural doctors, and that's really encouraging and inspiring for us as our students and junior doctors.
Any other? Smruti would like to introduce yourself.
Hello, morning everyone. I'm Dr. Smruti from India. I am a primary care physician from rural India. I usually join this place through Facebook, so maybe I was right now engaged in that. It's been third day here. I'm learning a lot of things. I'm looking forward to this conference to reduce the bridge between the developed and developing countries. It may take decades for us to reach to this level, but yeah, I'm gathering a lot of knowledge through my friends, and hopefully I'll do some great work for my country. Thank you.
Perfect. So let's talk. Everybody's everybody a little bit stressed to be on the stage, I think. But, so what are you liking the conference? Maybe we should talk about India next year, Pradyush. So are you excited, or who will be in India next year? Yeah?
He's not excited.
This is what happens when your conference is next year, and you're still preparing, you're inviting everyone. Everyone's saying this, yes, I'll come, but only God knows that who will come, who will not come. Anyway, invitation is still open. It's our job to invite you, and we can just promise you that you'll have a great time there in India. It's a lovely place, it's a great tourist destination, and also from academic point of view, it will be a great time there in India for you. And it's not only for the rural physicians, all the urban doctors can also join us there. It's open for all, medical students, nurses, paramedics, anyone who has got stakes in rural healthcare, they can join us there. Thank you.
I've just been handed the microphone. I promised Mayara that all our future conferences would actually have a student component in and a young doctor component, and I really must stress the young doctor. Perhaps we haven't emphasized the young doctor element as much as we should have, but it's about the rural seeds, and I'm so proud of the students and young doctors who've got this together, and it's going to take off. It's going to be really exciting. And, TripAdvisor is actually going to be outclassed by Rural Advisor.
I wanted to talk a bit about the clinical tours for next year, if you can tell us a bit more, because for people who are on the line, we've had some nice visits here. I went to an Aboriginal and Indigenous health group up at Yarrabah this week, and I learned a lot about both the challenges but also the real opportunities that people in those clinics are using to improve the health of the population. And so it's always great when you go to a conference if you can get out and see what the family doctors and their teams are doing and how the people are living. And so I just wondered if you'd like to say any more about what we're going to do in India for that. Is that...
You want to know about indigenous health in India?
No, about the tours, seeing clinics.
Okay. Yeah, because we are having this rural health conference, the main theme is there on rural skills. So what we are going to do, because over the years, we have found out that the skills which is required in rural and remote areas is quite different from what they're in urban areas. Because in urban areas, there are some high-tech investigations available. Patients come, and within a day, we come to a certain diagnosis, but in rural areas, they come, they get clinically examined, we make some differential diagnosis. If we think it's important to refer to the patient to the urban areas, it takes some 60 kilometers, 100 kilometers to reach there, the proper place, and there they reach a secondary health centers, where also most of the investigations are not available. Then the next travel begins by train to the main location, which is a capital city. It takes a day. So what we are going to do, that obviously point of care testing is important, but we have to keep in mind the affordability. Those who are there in the rural and remote areas, they're not so affordable to these latest investigations. They're very costly. And also the treatment modalities, all the latest treatment modalities which are available, are also very costly. And we also have very rise in NCDs. And all the latest diabetes drug, insulins, and all the latest drugs, DPP-4s, SGLT2 inhibitors, they are exceedingly very costly. We can't prescribe that to a rural population. So in this conference, and also when we talk about the guidelines which we have got guidelines for stroke, we have also guidelines for MI, which is rising in India also, NCD is rising. But do these guidelines apply in rural situations? When we have 3 hours time to go there, here it takes 3 hours to just call the ambulance there, And after 3 hours, we get a call that no ambulance is available. Then they have to go through a bike to the place, which is the primary healthcare center. They also not a facility to give a TPA or streptokinase. Then they are referred. So it takes a proper 24, 48 hours a day. We need to have a guidelines in the context, rural context. And that's what we can do in these conferences. Till now, there is no such things available. So we'll sit together, students, those who are working there, those rural physicians who are handling these things, and all those indigenous doctors who are also handling in their own way. We can also bring up and form some sort of, not a guidelines, some sort of way to help to deal with these problems. The thirst will be on these issues, that how we can change the population in their own way, in their own context, looking at their affordability, how much they can give to take treatment. That's what we'll do in this conference. Thank you.
Very good. I just was wondering, each one of us is kind of someone's drinking. Who is drinking coffee? Who is drinking coffee? Yeah. Yeah, coffee cup, yeah. Who is drinking water? Yeah. I'm drinking mate. Then I will ask for Karine to explain what is mate. And I think we have some Australian beverage that Tom brings with him. So can you introduce, like Karine introduce mate and then you can introduce? Yeah.
Yeah, so this is mate. This is a typical green tea for our region in Brazil and south of Brazil. In our state, Rio Grande do Sul. Here is our flag. Yeah. So this is a typical drink, and usually people drink it together. We drink with your family or with friends, and this is very nice. This one my dad gave me, so when I drink this, I feel like my family stay with me here. So, yeah.
So I've brought my Billy along here today. This one's quite shiny and flash. Usually it'd be a bit more dinted up. But a Billy, I guess, is an essential piece of Australian camping equipment. Typically it would be carried around by an Aussie bushman or a ringer, I guess, and they'd probably tie it to their swag, which is a rolled up...
every single thing you
Starting where? A ringer is someone who rings the cattle in. I think the term comes from. So they're I don't know how to break it down anymore. They ride horses. They're an Australian cowboy. Round up the cattle, riding a horse, and they might be out in the Australian outback for weeks on end. So they'd need to carry everything in their swag, which is a rolled up mattress, and they throw all their clothes, food, supplies, and carry it on their shoulder or on the back of a horse, and the billy would definitely be tied on there to go on the campfire. When you have a billy tea, you have some tea leaves in there mixed in with the water, and you boil the water and you throw the tea leaves in there, and then you swing it around and around, and the centrifugal force will keep the tea leaves in the bottom of the billy. It's a bit of a camper's trick. And if you want to spice it up a little bit, you throw some eucalyptus leaves in the bottom to really give it that nice, authentic taste. So, yeah, it's a billy.
You didn't talk about the damper, Tom. So when you're hungry sitting by the campfire, you can make bread just on the side of the fire, sometimes rolled around a stick, and we call that damper. And it's not damp, it's just kind of bread. Yeah.
At our Rural Health Club here at JCU, we have an Outback Experience weekend where we get a group of kids together and we take them out in the bush, and we have a damper cook-off, and it's always a big hit. So a damper cook-off. A damper cook-off is a damper cooking competition which we supply two teams with the raw ingredients to make damper, which is basically salt, flour and water, and then they can put jam or butter or Vegemite is the most Australian thing you can have on there, and then they have a competition to see which damper tastes the best.
I think I would keep hold of this microphone anytime you talk, Tom. as your translation service.
Thanks, Ruth.
So what's kind of drink that you're drinking? I was talking with Pradyush in India. He said, I didn't bring my traditional drink. What is it? Well, it could be like Smirra, talk about your traditional drink.
Okay, so tea is something, our traditional Assam tea is something very popular and dear and near to every Indian. Most of them want a cup of tea and then they can start their day. And then there are many, like the area I'm living, I live in a border area where it's connect to states. So there's something in local language they call as ambil. So it is a very holy thing. It's very rich in terms of nutrition also. This has a lot of ragi, a lot of our spices, and it's very cool. So especially when we have summers, they just prepare it and then they drink it. And everybody can drink, from a child to the elderly, everybody. So it's a very nice and interesting and healthy drink other than the tea in our country.
Okay, Japanese tea situation. Japanese also has a culture of tea, and also we are so comparable developed country, but still very aged society. So we are so encouraged to doing the home visit now. So far, sometimes I go for their patient's house and enjoy tea after our practice and have a talk about their families. Or yeah. So today, I also bring my Japanese sweets, so many in my bag. So after this cafe, so I can pass them there, give them all my sweets, and please come to us. Yeah, after this session. Yeah.
I think this is a really good idea for us to start talking. I think it was John. You talked about the other day the power of being invited to have a cup of tea. I'd really like us to think about how it is that we engage with our patients when we visit them. So in the Torres Strait, if I go and do home visits, and when I sit down, I say, "How's the fishing?"
I think in Brazil, if you go around like 5 o'clock, 6 o'clock, in south of Brazil, Argentina, Uruguay, everybody will be drinking mate, or if it's very early. So sometimes if you want to have some serious conversation with your mom or your dad, let's have a mate. But if you want to have some funny thing and get together, let's have a mate as well. So it means a lot for our community. And if you go to any house, you should drink a mate.
Mayara, I've seen in Argentina, mate, for people who haven't grown up drinking mate, I think the wonderful thing about mate is that it's a shared thing. So, yeah, why not?
Yeah, perfect. If anyone would like to try, we can pass the kuya around. Yeah. Here we go. Yeah. Yep.
Going on from tea and coffee and the ceremony of drinking, and I know it's a big thing in Japan, but you know, when it comes to resilience, and we had a meeting, we had a workshop on resilience yesterday. Actually, one of the most powerful tools for resilience is meeting with your colleagues and your team in your surgery. And increasingly you find actually doctors not leaving their room, just buried in the work they've got. So I would encourage people also to go and share a cup of tea or a cup of coffee with your colleagues, with your team, and with your patients.
Sure. And in Taiwan, what is the traditional drinking and how do you engage with your patients?
We share with our patients. I'm not sure, but I have to introduce the black tea in Taiwan, most famous in Summer Lake. Have you ever been there? I think that it's a different smell from black tea here. Yeah, I hope I invite everybody can go to Salmon Lake in Taiwan. Yeah, we should share with our patients frequently, I think. Thank you.
You're welcome. So, as you are talking about tea things and everything, that was one of the things that I was trying to bring about the tea. That the Japan.
Yes, as you guys say, the green tea is very common drinks in my countries and as well as your countries. So that we drink after meal and to relieve our stress. So I wanted to bring the green tea today, but I cannot get today because today is the latest day. So, sorry.
I was going to change tack slightly because I think one of the features of being a rural general practitioner is that you meet your patients in the community that you live and work. And for us in Australia, and I have to say in the UK, that was often, and is often, in the pub. So it's usually over a beer or something like that. And it may loosen tongues a little, but it is a very convivial way to meet people and get to know them beyond the clinic setting.
Perfect. And as we are here in the conference and everything, have done loads of things. Today at the afternoon, we will construct the call to action that we're working very, very hard. So I'd like to ask for the students that are here and the young doctors that are participating in the construction of this document. How are you feeling? What do you think that we should include that? So moving from tea and the coffee and everything for call to action, what is your expectations for the future of rural health? Maybe Veronica, would you like to talk?
Hello. Zoned out a little bit. So my hopes for the future of rural health is that all of the current students and young doctors, I guess, have a better opportunity to train, have a good community around them that supports them in their work, that they're able to serve their community as well, and that they're prepared for all the future challenges that I'm sure we're going to face.
Okay. Yesterday we stayed working until very late doing the call to action, so it's in our mind. I think I dreamed with the call to action paper. But what we would like to do is shake everything and try to bring new ideas, and that is what we are trying to do, and the rural cafe and everything. So maybe anyone would like to comment the rural health success stories, everything that we are doing now. Yeah.
So this afternoon we have two workshops also. One is about how we can attract students today for be rural GPs tomorrow, and another about how to do a local rural cafe. So if someone is interested about this, you can come.
You mentioned before about rural success stories, and Veronica mentioned about challenges. And I think it's all about trying to get the right language, isn't it? It's trying to look at, yes, there are challenges, but there's so much success in rural, and there's so much fun in rural. One of our health ministers said that she really liked, and she does live, in a rural area, and she said she really likes a rural area. And she wanted people to want to come, that they needed to be valued for coming, but she really wanted them to come. And I think that's what we share as a group, is that love of rural areas, the love of our patients, the love of continuity of care, the love of having a wide generalist practice that allows us to follow those patients through from our practice, through to our hospitals, through to our back into the community, and know them in that context. So I think it's really important that we I think too often we can say how tough it can be in rural areas, but I think we need to celebrate how much fun it is too. And I think the rural stories that you've got, the success stories, are just wonderful celebrations of that. And it's great to see the young students be able to share those celebrations too.
I'd be interested to hear people, particularly the guys who've been working for a while in rural, talking about how that builds up. Because some of my students in the UK kind of worry a bit about, you know, being people in a community for a long time, and yet we hear lots of examples about how that really works well in practice. So I don't know if anybody would like to comment on that.
I just want to, today in the morning I was inspired by Amanda in terms of having a goal, and part of leadership is to having a common goal, and if we focus on rural communities, and that's what I got from the patient input in what we want to do for the future. So I got that very much from you, and general practice has always been about patients, and that's the difference, really the main difference in general practice is the patient is taking control, and the discussion between the patient and the doctor is what is effective. It's not what we tell them to do. Actually, it's about this discussion. So I want to, you know, and it works in rural communities, and actually talking about getting out to the community rather than being in your practice and the medical home issue, and going out from your practice to the community and have a cup of tea with the patient at their home and see how they function in assessment for over 75, which we do here in Australia. We get our nurses to go out to the patients, see what's happening at home, and have a discussion about it. So again, going back to the community, have a common goal to raise the profile of rural medicine is a fantastic thing to do.
Well, before I realised I was going to be an academic, or really what part of the starting that story, I was involved in helping to write a book about rural practice, and we were living in Gippsland at the time, and I interviewed one of my colleagues, James Brown, and who's a GP, rural GP in Trafalgar, which is a minute little dot on the map in Australia down south. And he described how inspiring it was to be a rural GP, to see patients in the clinic where you get one perspective, and then when you go out into the community you see them in a different perspective, and that adds to your clinical understanding and knowledge and your clinical reasoning, in fact. And the example he gave me was seeing a young child with depression. And this was very hard for both him as a doctor and as a father, and obviously for the family. And yet when he went for one of his own children's academic events at the school, he happened to notice that this same young depressed boy had painted the most fantastic picture and had won an award. And so it was just so wonderful for him to see that actually when you are feeling very despondent and about patients, that actually there are other sides of their lives that they're doing very well. And it was that sort of story that we kept getting that made rural general practice, I think, have such a comprehensive and complete whole picture of the individual, the family, the community, that kind of brings it all together. Ruth, you had a story.
Yeah, I've got a story that fits in with that, I think, but I want to pick up on that point. I think one of the things that can give you resilience in your rural practice is you might go through what is a really traumatic day with a very sick child. And I remember the day that my husband was involved with the child of a close friend of ours who had a febrile convulsion. Febrile convulsion, sure, they come and go, but this one kept on going. He was late home for dinner, and I rang him and I said, are you coming home soon? Come on. And he said, doing a transfer. I went, oh, okay, well, where, and finally he said, Liz says, I can tell you, it's Charlie. Now, Charlie came through that okay. I've been to about 6 birthday parties for Charlie, and last year celebrated his 21st, he's finishing university. So you can tie that circle in. But the real one I wanted to tell you about is one of the most difficult things I've done in rural practice. A friend of mine, end of a long day, phone rings, surgeon from our regional hospital. Oh, Ruth, thought you might pick this one up for me. It's your patient, I'll call her Maggie. Did an appendectomy on Maggie. Oh, it's a bit, she's got a cancer. Can you ring her? It'd be better if you ring her. Now, what he did not know is that Maggie was a close friend of mine. So at the end of the long day, I had to go and tell Maggie that yes, she had appendicitis, and that was cured, but she also had bowel cancer. And at that time, I said to her, Maggie, I will travel this journey with you. We'll be together. It didn't go well. Over the next 6 months, that cancer spread and spread. We managed palliative care in our small community, and gee, it was tough. It's still tough even actually to talk about it now. But the thing that happened at that time when I was feeling very vulnerable and really worried that whether I was doing it right, any time I went out in the community, somebody would come beside me. She was a very well-loved, liked woman, and somebody would come, just appear at my side and say, Ruth, we know what you're doing for Maggie, and it's wonderful. So I felt affirmed, and even though it was hard, I was given strength by that community support. And that's one of the really wonderful things about working in a rural community.
Perfect. I think Zakur would like to say something.
Yeah, thank you. Rural Café is not like so much formal like that. I would like to take the opportunity to ask and request student, please think and try to do a research. Young doctor, please do a research. And GPs who are already established and doing a lot for rural people, please official your work, you are doing a lot, and ultimately it will known by the world you are doing for people in rural areas. Actually, more than 90% health data or biomedical research is done in developed country. Unfortunately, 10% research comes from developing country and low income countries. So we are in high need to come more data to plan for planner. Actually, Jim from attached to the WHO, he said that no data from developing country. The situation is not like that in rural areas. One doctor see more than 50 patients in a day. And I am the real fact, I am the conducting doctor. Someday I see more than 50 patients. So not much time to do research, and as well as our structure is not like that. In every day you to put some times to in oil-equipped internet gallery to shoot something. So we have to occupy and we have to somehow to overcome it. And please do at least one research for everybody. It's my humble request to you. And we will put it in ONCA working party on rural practice research group. It will be a property and it will be a data to use around the globe. And I humbly request again all of you to at least do one research, or at least contact one research to ONCA working party of rural practice. We are very grateful to you, and it will be a lot for future planning and as well as rural people around the globe. So we are main drinking is water. We have more river in my country. 3/4 of land, 3/4 is water, 1/4 is land. So we are very fond of water, and absolutely clean water for drinking water. And alcohol is not so much available in my country. Don't worry, in international or national program, we have plenty of options. All things are there. So you're please welcome to visit Bangladesh for exchange, for visit or tourism. We have world largest sea beach in Cox's Bazar. So please welcome. Thank you.
Perfect. We have some questions coming up on Twitter. Actually, we had an issue, a technical issue. We have broken the link on YouTube, so Ewing is doing it on Periscope. So we just moved from one platform to another, which is great. So, but anyway, if the guys can get another link, they can tweet it on the back of the tech guys. So this is why we are having some moving in front of the stage.
It's being a rural doctor.
Yeah.
Yeah, so I'd like to pick up on one of the questions we've had through Twitter on how do we improve rural training pipelines to get people into rural careers, and that came from Shannon Knott, who gave one of the presentations yesterday. One of the things that I've been most struck with listening to the conversations here is this, what you're putting on offer, what you're putting on the table is this inspirational concept of the challenge of rural health, that you're looking for the brightest and the best. It's an active lifestyle, an active engagement where your principles of social justice, the opportunity around public health and equity is really being underpinned. And I think that comes in tune with today's social consciousness and a global reaction to some of the dominant macroeconomic perspectives for the last 30 years, in general wealth inequality and inequity in terms of access to social education, to health, to many other things. So I think what you're putting on offer, what you're putting on the table is appealing, it's attractive, and we need to get that message out. And two things on that respect, I think. For many, many years, and if we look at the literature, if we look at our evidence, WHO recently commissioned a paper on the experience of posting and transfer within healthcare systems. And rural posts, rural opportunities are considered a punishment. You get placed into a rural occupation or a rural position, and you spend months and years trying to get out of it. And in many, many countries, and I won't name them, but the evidence makes it very clear, often you have to bribe your way out of a rural position to get back into the urban areas, to get back into hospital, to get into the specialization, to get into the opportunity for dual practice, to supplement your wages. So these are two very, very different realities. How, and come back to your point about the call for action, how will you as students, as practitioners, as engaged, tell the stories that send that message about this attractive career opportunity that's in front of people to change the narrative for the 21st century?
Yeah, well, I think we have the rural health success stories, which is going on. Maybe even producers, Mirut can talk more about that. We are changing now. Exactly at this moment, we are changing the whole perspective. We have loads of tweets about Rural Café. I think you are just experiencing the change exactly now through social media, getting together with people, drinking tea, coffee, whatever, and getting the chance to discuss with experienced GPs, experienced and really important people, and students, and young doctors, having the humble to get together and talk about rural health. We didn't see it in specialist care or whatever. Here we are together and getting together. So I think this is one of the ways of change. We have loads of ideas and the rural advisor and everything. So I think we are growing and changing.
Can I just enlarge? I entirely agree with you with what Jim said. And just go on to talk about these compulsory placements that people get. Actually, it's not just, lower middle income countries. It actually happens in Europe. In Greece, students are sent out to be the GPs, because the only GPs in Greece are the rural doctors. And I went to a meeting once where there was a young doctor from Colombia, and actually he'd been sent out, and he was telling the painful experience of ending up in rural practice, just qualified, and having to deal with a really difficult labour that he just couldn't cope with. And, isn't it perverse that we tend to don't value rural people and their lives, that we send unqualified people to deal with them, and actually we have the qualified people who live in the cities. So I think we need to turn that culture round.
I sometimes ask people to explain why people from my community are worth less than the people who live in the big city. And nobody can actually explain that to me. And I think it's a really useful position from which to argue. It's a very powerful thing. The members of our rural and remote communities' lives should be lived in equity and not in disadvantage.
Can I add another little story? Oh, you go first. You go first.
I guess I was just going to comment on my knowledge is more limited to Australia's challenges in rural health, and I know we have an imbalance of workforce, which probably isn't as significant as some of the other countries around the world, but is still something worth working on. And like it was mentioned, they've had to bribe people to go rural. Medical schools have produced more medical students, and none of these things are really tackling the problem. But what shows really significant research is that if you recruit people from these rural communities into medical school, then they are the students who are most likely to return and spend a lifetime working in these areas. And I think building on what Mayara presented on early today, this truly is empowerment. If we take these students from the rural communities, train them to be skilled health professionals, they'll be the ones that return and look after the people in rural communities.
So there's so much to all of this. And certainly in Australia, the rural health movement happened over 20 years ago. And one of the early requirements was for all students to have at least 4 weeks out in rural areas. And the idea behind that was basically giving them some exposure, which actually Amanda referred to in her leadership talk this morning, that she had a deficit of knowledge about rural. And so the idea was that all students with some rural experience, even if they went back to the city, would have a better understanding of where some of their patients may come from, may go back to, would have a better understanding of the referring doctor when the referring doctor was from a rural place. And even when they were going into policy positions or research, would still have a better understanding of really the rural lens. So that was one of the key underpinnings. The thing is that certainly, as you were saying, Tom, that there's kind of more bang for your buck if you are putting energy into rural students with a rural background and then giving them a positive rural experience and then ongoing targeted training in the vocational space. And that's held up really over the last 20 years. Why I took on this position with the University of Queensland, and some of you may know it as one of the largest universities in Australia, I had said at the beginning was from a story on the Family Medicine Rural Café. And I'm glad Veronica is not sitting right in front of me, because I would probably embarrass her, because it was her story in Croatia that made me feel, what have we missed? Was we've spent over 20 years doing this, and we have written books, we've run conferences, we've done flyers, manifestos, videos, done all the training, and yet still the understanding of what rural training needs to be, and needs to be positive and skill up both the supervisors and the students and the young doctors to be able to cope with all the demands. And it's more than just being able to cope with all the demands, because we never know what those demands are going to be, but flexible enough to take on whatever challenge is coming that makes the difference. And just recently, in Australia, the requirement has changed that only 50% of the students have to go out for a rural 4-week placement. And I think that's a loss to the country. And I'm advocating for it to be changed back to being 100%. Luckily, my university didn't notice. And so we still send out 100%. And actually, they all have a fabulous time. They go under Bruce's direction. And it's a very positive experience. In fact, one of our students said, if you don't try it, you don't know it. And even if you come from one rural community that may be a seaside community, you still don't necessarily know what it's like out in the plains and farmland. And so that there's lots of experiences to be had to help you find where you want to go into practice at the end.
Perfect. We have Amanda, Ayman, Karin, and Pradyush to talk. But just before, is Joe in the audience? Yeah, he asked if he could come. So please come, Joe, as well. I go to the floor, and then you can sit here. And Amanda.
It's a shame Jim's going, because I was just going to make a bridge with the example you gave, if I may. So you were talking about under-supported compulsory placements where the doctor, if you like, has a bad experience, and so we get a negative story coming from a rural community, from that person usually, versus the example that many people have talked about, but Sarah finished with just then, about what happens when you have a really positive educational development, which is probably trained, and people then have a positive experience and hopefully a positive career. And the thing that I wanted to pick up was that the two are not the same. Putting a young doctor out when they've just finished their basic training into a public service post is one thing that some governments feel they really have to do, because that's the only way they can get any supply of service out to those people. But if what it means is people think that's the same thing as rural family medicine, as a specialty, family medicine as a specialty and a proper career and a proper training, then we've got to really keep pointing out that the two are not the same thing. And general practice around the world, whether it's urban or rural, if I say, has some of that problem that the old-fashioned, the out-of-dated model of people not getting a good enough training, not getting good enough resources to do the job that we need them to do, is the big challenge. And we just need to make sure that our discipline, wherever it's practiced in the world, is distinguished and upskilled and updated from that, because otherwise the confusion is there, and that's not going to help anybody. So thanks for raising it.
Emma?
I'm just, I think a couple of problems that face people in rural communities would be isolation and in general practice in particular is uncertainty. And creating this networking and using the technology to have mentors and network with each other is a fantastic privilege of the technology nowadays that wasn't available in my days. And actually what I'm hearing in the conference today and the young movement of getting us all together, whether we're young or old, and getting the discussion happening and sharing the experiences actually would make a huge difference. And I heard that very clearly in the conference today. And I'm going to take it back to the rural faculty and make sure that we are all engaging as mentors for the future. And because that's our responsibility actually to get there. And there is methods of doing it, which is not as difficult as people say. I mean, FaceTime, Facebook, having the cafe, having other things that people can really connect face-to-face and have a discussion, I think is very important.
Karin, I think.
In Brazil, we don't have any rural practice during the medical students, and we don't have yet a specific rural training for GPs. So this is a big challenge for us. In the last 3 weeks, I could spend some time with Dr. McPhee in Emerald, and this was a very nice experience for me. I know I can share this experience with my friends and my teachers when I back to Brazil, and I know I can try change some things and help to improve this in my country. So the idea of the rural advisor, it's turn this possible for more students around the world. I think here in Australia we have a great rural GP, and I think if more students can do this experience, we can improve this in the world. So, thank you, Winnie.
Okay. I just want to tell you about the Indian perspective about this rural postings. In India, we have got, in some places, there is compulsory 1 year extra rural postings to all the medical students who pass out at 5.5 years. And it was strongly rejected or opposed by the medical students. And I also feel that the government should try to create an environment where a student by themselves, they volunteer to go towards the rural health care. If we force them to go towards the rural health service, they won't serve it well. And it's not their heart won't be there. Their heart will always be there in the urban areas. So they won't get the link between the urban people. They won't connect with them properly. So I think we should create, in fact, we should make the rural health glamorous. So that everyone should go towards that. It should be like a profession that anyone should think, yes, after passing undergraduate, yes, I should go to rural health areas. Now urban is like it's cool. They can go drink, have pizza. In rural area, you won't get that things. So I'm not saying there should be that. You should provide them a secure environment where they feel secure. They should have a proper salary compared to what the urbans are getting. Then obviously they will go, because there are other things in the urban areas. There are more pollution, there are more diseases, and cities are more. They won't have a longer life than those who are having in rural areas. So obviously there are many positive points which they can highlight them. That's the way we can do. And one more thing about this rural health success stories. When we started, there were many complaints that why you have kept the name rural health success stories. Because in rural health, all the stories may not be successful. There could be many challenges, there could be many problems. Why you kept them success? And I told them that there are challenges, there are problems, but if you report any challenges and any problems, it becomes successful. It's to the wider audience to reach, and that's the success stories. Thank you.
Thank you, Pratish. You have brought up the point that I wish to make, that really it isn't helpful for us, for our communities, or for the future of rural health to continue the deficit dialogue. There isn't not this, there's not that, it's time to start talking about the success. We have in Australia, by setting up a clear pathway, the pipeline we often call it, to competent, confident rural doctors to follow. Yeah, if by doing that we have set up, there are success stories. We are filling the vacant places in rural practice and rural hospitals. We are beginning to change the outcomes of our rural communities. It can be done. And until we change the discourse to a positive one, the change will not be spread.
So through this discussion, I'm thinking about the role of young doctors working at the rural area to attract more young students to come. Yeah. So I also welcome so many medical students to my small community hospital. At that time, so I a bit pretended to be happy because I'm happy, so that they will want to become like me. So that I also show my kids photo and gather in the local festival wearing a costume, and so my work-life balance is very happy all the time. So that really this community is very nice as one of the people living there. So I think so. So in Japan, sometimes this happen. So many veteran, experienced doctor working at the rural area and welcoming medical students for as a local rural health and medicine training. But there's no middle manager. We need more young doctors. So we are like your brother, older brother, so that you can feel the sympathy each other. Okay, this is a leader. Next 5 years after, or 10 years after, I will not be like this. So I think so if we can recruit more young, energetic doctor in rural healthcare, so that's very nice to show your role model. Yeah, that's my.
Perfect. Just to bring another question, and Smiruch would like to talk also, is how do we address global medical workforce challenge and maldistribution? So just for us to think about, and Smiruchi.
Okay, so in continuation of what we all discussed, I do feel that if we have a very strong hero or icon in our mind or in front of us, we can really deliver better. Like, I have written one story on the blog, like, I am rural female GP by choice. So when you do something by choice, your intention, your positive energy, that flows in, and you definitely start enjoying the workplace, whatsoever it is. And if you have a strong icon, like in my case, my dad is my icon. He is an obstetrician, but he's a hardcore GP. And though he had all the lucrative options in his time, some 34 years back, he chose to come back to his roots. As I was going through the live feeds, I did read one, like, you post the rural doctors into medical school and they should come back to their roots. So yes, I did follow my father. I did my graduation, post-graduation. I came back to my roots. And I do have another icon. He is my in-law, but he is a pediatrician by graduation or degree, but he also is a hardcore. Like, he sees the children from day 0 to the 84 years of age, and they are his patients. So when you see such icons, let it be a positive or negative side. The coin has both the sides, but it's our perception, how we look into that. One of the live feed was saying, only project the positive. No, you should project the negative. You do learn from everything you see, you face in your life. Let it be a positive or negative. It is your approach, your intention, how much you want to absorb from that. On Success Story blog, Rural Health Success Story blog, we do feature some stories. They don't have a very positive ending, but there are lots to learn. How the physician friend has fought with that problem, how they overcome, how they dealt. Because you should know, as a young physician, to deal with all the possible kind of emotion, because that is very important in rural places where you don't have a very strong backup in terms of your seniors or whatsoever. So, yeah.
Perfect. Can we talk about the challenges and maldistribution? Or the fire in the belly part as well?
Just very briefly, the one thought is that we have a problem with challenge. The word challenge, because when I say something is challenging, I actually mean in a very positive sense. It's stimulating, it's exciting, it's something I can get to grips with and learn through the process. Whereas I think when I talk about something being challenging, the other person may receive it as that it is a problem, it is difficult. And so I just wonder if we could come up with a better word to describe it.
I think you need to pair it with other things like good education training, confident, competent doctors who can rise to challenges. I think it's about, and I think that's the thing, even though I was actually on a bonded scholarship, I went out to Theodore and stayed there ever since. But the reason I thrived, I'll have to ask my wife what the correct term is. The reason I did well was because they intensively trained me before I went out there. And all the people who were around me said, we know the challenge you are facing, we will train you to face that challenge and be able to thrive with that challenge. And I think that's the challenge for us, in fact, as medical educators and others involved in rural practice, is to make sure that you guys, when you go out there, go, I'm ready for this, give it to me, yeah, I'm right. And that's all the aspects, right, from treating people you know, having to deal with a bus accident where there are kids who are from families that you know, all those sort of things that you have to be able to deal with, they're terribly satisfying that you can do that and you can do it so well. Thank you.
Okay, I get you to say fantastically satisfying rather than terribly.
Let's talk success stories. In 1997, the Australian College of Rural and Remote Medicine was formed by a group of rural doctors who wrote a curriculum looking at what they needed to be able to do the work they did. That college has grown and grown, and we now have something like 400 registrars at the time. She's shaking her head at me. Sorry, 450. 750, go on, I'm sorry. I don't keep numbers in my head at all. Yeah, that's right. And that has been tied with a raft of policies that at a national and at state levels that have really supported rural doctors, doctors going into rural in Australia. In this state now, there are increasing numbers of rural doctors every single year. We talk about the pipeline in Australia, and why we use that word is Australia is a country that does not have enough water. The most precious thing in any community is the water. Now, where you don't have enough water, if you have a pipeline bringing the water, that is a wonder. And it needs to be a pipeline without holes. You need to make sure that you're getting a good stream of water at the end of it. We have created now in Australia a pipeline for doctors out into rural country towns, remote towns, rural hospitals, so that now there are flourishing health services in some of the poorest and least developed towns. This is a success story, and it can be replicated. We had an international summit on rural generalism, and one of the things that we talked a lot about on that day, this is just 3 days ago, was the need to look at models and apply them to the distinct differences in each country. So yes, look at what has happened in Australia. Think how your own country and community is different and what you need to tweak to reproduce this success.
Ruth, I'm sure you're going to shoot me afterwards. But, but you know, Australia has been really successful, but it's put huge amounts of resources into rural health. And you know, come on, no, let me finish. It's put huge amounts of resources into rural health. The ILO report talked about the inequalities across all the financial areas, you know, from rich countries to poor countries. What we need to do is, how do we translate that in countries that are not prepared to develop rural clinical schools, you know, rural pipelines, longitudinal placements, generalist programs. And I'm not being critical of Australia there, but I think we actually need to see this in a global perspective. And that's the real challenge. I don't know the answer to that. But, you know, it is the result of a huge amount of investment. And getting governments to invest in the way that's happened here is going to be the challenge for a lot of places. And shoot me.
No, I'm not going to shoot you. I'm just going to educate you, John. There are plenty of low-cost models of the pipeline. In one of the poorest countries of the world, the Philippines, they have a beautiful model of education of rural doctors. They take rural community members who are sponsored by their own community to enter into medical education, who take a stepwise approach. They become a health worker first, and if their community is impressed by their skills and their engagement, they go on to the next level. There are other models in Cuba, in come on, Sarah will be able to help me. But there are plenty of other models that do not have the investment that Australia, the rich country, can have. You don't have to have a rich country to have a pipeline. You just need to have commitment. So, and the other thing that I would put, if I was sitting in a rural community in a developing country, I would say, why is our dollar spent, why is my health dollar spent in the city when more than half of our population live in the country? Where is the equity?
Yeah, well, okay, just before, like, I have Amal and I have Kensuk. However, we have time here. So I would like to ask for each one of us, like, it could start with Amal and then after with Ken, but it's your last talks, and then we will go and give the microphone from each one of us to do the bye-bye, and we need, well, I need to be sorry, we should be talking for the whole day. However, I need to be strict with time. So I will pass my word to Ayman, and then each one of us can do the closing and the final comments. Is that okay? Sorry, yeah.
John, I'm just commenting on what you're saying, and I'm proud to be a member of the rural Wonka because of exactly what you're saying, and we need to understand what other communities are suffering with, and we need to have this networking, and actually that's the idea of rural Wonka, is to get out there, but it's also we need to celebrate the champions around us too, and maybe it's the ideas rather than the money, and the sharing of the concept and getting out there and understanding. And I think from today I learned a lot about other communities around the world, and globalization is happening, and we need to be part of it, and we need to support it and support other people. So it's great work that you're doing, actually, and I was just very impressed with and the young generation coming up, taking the lead, and it's just fantastic.
Perfect. Ken, your final comment and
yeah. So I agree with Jerome. I was working on the border between Burma and Thailand. I was in the clinic, in the very small clinic. So we have no facilities, and many patients are coming from Burma. They are migrants and immigrants, so they have no insurance, they have no money, so we give the medical services for free. So I think the places, the clinics, where the money can get from the fund all over the world, it's very nice. But most of the clinic doesn't have many money from other foundation and other government. So I think the political issue is very critical issue when we do the rural physics, rural medicine. Yes.
Perfect. Prajit, your final comment and...
Yeah. My final comment, like every time I go, where we discuss about rural success stories, to request you all to submit at least one stories to our Rural Health Success Story blog. We are going to telling in every conferences, but we get very less response. But I expect this time from Australia that we'll get many, many good responses, because we have got many things to tell, and our blog could be the good platform to share your views. Thank you.
Stories or poems or music, whatever you want, not just stories, whatever you can express yourself. Can Amanda, your final comment?
I think the president of Wonka should go last, actually.
Oh, that's okay. Sorry, Bruce.
Look, as the secretary of the Working Party, I just think this has been a fabulous conference. It's a fabulous cafe, but it gives us all your support to take this forward to WHO and to the other countries of the world, and to find the low-hanging fruit, the stuff that can be done easily with a bit of political commitment from governments to say, we want to do this. So you've challenged me. I rise to challenges, looking forward to it.
Perfect. Sarah?
Thanks. Well, great family medicine, rural family medicine cafe. Congratulations, Mayara. I think that one of the leadership strategies is about visiting and being visited, and that you get a lot of inspiration from either visiting or being visited. So I think that now we can do this more through social media. So I hope that we continue to expand from here, and look forward to being part of it.
Perfect. Ruth?
I think I've said a lot. The wonderful opportunity to share and explore ideas with such a mix of people, and good news stories coming out.
Thank you for the brilliant time. It's very nice time for me to share the many issues and the political, and to share the rural physicians' ideas. So thank you so much.
I mean, I think, going on from what we're saying, and thank you for not shooting me, Ruth, that we actually have to engage with World Health governance. And, you know, WHO may not have any funds, but a huge influence. And if we can get this into mainstream thinking, and that's the notch that we have to get up, then I think that we're going to make that difference, and we're going to be able to show that what you've done in Australia is possible in other parts of the world. So just thank you very much. Thanks to Ewan down there. Thanks to the technical team. One last question. Can we do this in Dublin at the World Health Workforce Summit? Because I think they need to see it as well.
Yeah. We need to check, but I hope so. Joe?
So, yeah, I just wanted to say thank you very much for involving us. We talked about maldistribution. One of the things about maldistribution is the lack of social connection, and using tools like this really help us to improve our social connections. And I'm in the time, you said that in your day, these things weren't available. This is your day. This is our day, and this is not the preserve of the younger people only. We know we all of us need to engage with social media and play and enjoy it, because it's through that play that we'll then start to learn how to use it more serious things, like the social connections that we're now demonstrating.
Yeah. Zakiu?
We can't change the world, but we can make a start. Somewhere it will start. So thanks, Rural Café. We are not looking for fund every time. We are looking your help, we are looking your mentorship, we are looking your motivation. So at least one student you pick to give some motivation. Thank you very much.
Yeah.
Thank you very much for being here. And so on behalf of the Young Doctors Movement in Asia-Pacific region, we want to create a new word, Rural Young Doctors Movement, so that we can be more nice role model for more nice medical students. Yeah. Thank you.
Thank you. On behalf of medical students in Australia and across the rest of the world, I'd really like to thank Mayara, John, Bruce and the rest of the Wonka Working Party in Rural Health for their efforts in making conferences like these more accessible to medical students. I'm so excited for the 18th Wonka World Rural Health Conference next year in New Delhi, and I hope to see you all there.
And thank you for our experts sharing about rural medicine. And we, Puri Christian Hospital, are expecting medical students to Taiwan, to Puri for the experience, experiencing the village, I think is something like a rural practice. We are expecting medical students or young doctors and come visit us. Yes, thank you.
I remember when Mayara and Bianca invited me for come here. I looked at them and said, "Are you crazy? I don't have money for this. This is so expensive." And so they said, "Oh, we can try." And now I'm here. So, yeah, I like the phrase. We can start doing the necessary after the possible, and so when you realize you can do the impossible, I believe together we can do the impossible.
Perfect. Okay, so thank you, Myra and team, for this extremely lively experience of Café. And to sum up, I'll just say, please do share your stories, your experiences. Let it be positive, negative, neutral. Because I always believe you never know at what minute in this whole big world your story or your experience can inspire somebody to become a rural GP. In my life, I assume I have managed to inspire maybe 5 students. They may join rural practices in coming future. So yeah, Myra and Pratush has created some great platforms. So let's make most out of it. Thank you.
Okay, a lot. When I said I should go last, I really meant last but one, because of course you are our host. But I just like, with the presidential hat on, to say, well done, everybody. Whatever you're doing out there and whatever you're going to do with this, let's take these messages forward and out, upwards and down, to our younger colleagues. I shall certainly be telling my medical school all about this and our students. But also I think the discussion just at the end about the pipeline and the transferability of the models, I really think that if we understand the principles of what is needed and the values that drive us, then we can hopefully help our colleagues in other places who haven't yet got a good model to see what is possible in their place that they can take from a good model, but will still be appropriate for them. And I think we've just got to be absolutely clear what the core principles are about accessible, affordable care of good quality that continues over time, that's right for the community. And we can all start doing something with that every minute of the day. So well done, and thank you.
So the final, the closing. Thank you for everybody that is watching us. I'm really thank you for Ewing, please a clap for Ewing that made the Pyroscope, and yeah, well, his colleague that I do not know the name, who is like Matt. Also, thank you so much. Thank you for the guys that is on the back. Thank you, you're awesome. And thank you for everybody that is here on the stage, that's watching us, and all of you that passed this whole morning here today. I'm very grateful, and I think we have so many things to construct together. You are invited for the next Café that will be on 10th of June, and it will talk about equity. What is family medicine, actually, and then in July about acting in rural. So I hope we could keep going and constructing this together. I'm so thankful for everybody that is here and then who came over, and everybody. Thank you so much. A clap. We are finishing our broadcasting, but we are not finished on social media. Keep going on Twitter and on Facebook, and we try to bring the inputs there. See you.